I just want to thank everyone for joining us this evening. I think this is also being, I think, taped and streamed through the city of Greenville as well. Welcome everyone to, I guess, kind of our first virtual event for Black History Month here in the city of Greenville. I want to thank you guys so much for joining us this evening as we have a conversation about Black health and wellness here in our community. For those who may not know, I'm Nicole Williams. I'm Delegate Nicole Williams. I represent District 22, which includes the city of Greenbelt. I actually live here in the city of Greenbelt. And so it is really my honor and my privilege to be here tonight to moderate this really awesome panel of experts and just experts that we have joining us just to kind of really kick off our Black History Month activities here in the city of Greenbelt. And so what I'm gonna do first is that I'm just gonna give a little introduction of our panel, tell you a little bit about these amazing individuals that we have joining us this evening. And then we'll get into a couple of questions that we had prepared beforehand for our panels. And then we'll just open it up to just general Q&A for whatever questions that folks here may have this evening. So first, I am going to start with my awesome colleague, Delegate Jocelyn Pena-Melnick, who represents a part of Prince George's County and Anne Arundel County and has served as a state delegate since 2007. She currently serves as the Vice Chair of the Health and Government Operations Committee and chairs the Public Health and Minority Health Disparities Subcommittee. She is also chair of the Maryland Health Insurance Coverage Protection Commission for the state of Maryland, and has served on just a wide variety of different boards and committees, including serving previously on the board for Costa Maryland, just to name a few. She has been named one of Maryland's top 100 women by the Daily Record in 2021, 18 and 2015. And prior to serving as a state delegate, she served on the College Park City Council. Delegate Jocelyn Pena-Melnick immigrated from the Dominican Republic to the US with her single mom and her sister. Her humble background, her mom worked in New York's garment district and often struggled to make ends meet. But besides those tough circumstances, Jocelyn succeeded and is a star in her own right. She went to law school, and during one summer in law school, and I found this out by knowing her bio, I did not know this before tonight, she worked in Alabama to represent prisoners on death row, and also one summer was in Ohio in the farm country there, visiting migrant farm workers and fighting for basic living conditions and safe work environments and fair wages. After Delegate Pena-Melnick got her law degree, she took on court appointments to represent abused and neglected children, provided criminal defense for the poor, and later joined Eric Holder's U.S. Attorney's Office and prosecuted criminals by working closely with police officers, witnesses, and victims in the community. And so she is just an amazing person. She's been a great mentor for me personally since I joined the House of Delegates. And so I'm so happy that she was able to take the time to join us this evening. Also joining us, we have with us Dr. Dennis Antoine. Dr. Dennis attended Howard University School of Medicine and went on to Johns Hopkins for internship in internal medicine with a residency in psychiatry. He completed an NIH-sponsored postdoctoral fellowship in addiction research at the Behavioral Pharmacology Research Unit at the Johns Hopkins, and is a duly board certified in psychiatry and addiction medicine. He is currently the director of the Cornerstone Clinic at Helping Up Mission, the Addiction Treatment Services and Center for Addiction and Pregnancy Programs at the Johns Hopkins Bayview Medical Center. And these programs treat individuals with substance abuse disorders and co-occurring psychiatric conditions who often have encountered stigma and also other social disparities. He serves as a core faculty member of the Johns Hopkins Center for Health Equity and is co-director of the Congressional Depression Awareness Program, which aims to equip select members of the Baltimore area congregation to recognize and empower individuals within their network. So we're so happy to have him with us this evening as well. And then last but not least is Dr. Alexis Hammond, who is a graduate of Spelman College, as well as the Meharry Medical College and Georgetown University School of Medicine. She completed her residency in psychiatry and a fellowship in addiction research at the Johns Hopkins University School of Medicine, where she is currently an assistant professor of psychiatry and behavioral sciences. Clinically, she is a board certified in both psychiatry and addiction medicine and serves as the associate medical director at the Center for Addiction and Pregnancy and Addiction Treatment Services. Her clinical and research interests include identifying innovative and efficient treatments for substance use disorder and other psychiatric disorders, especially with the use of technology and among special populations such as pregnant and parenting women. So thank you guys so much for joining us this evening. I think we just have to just give them a little clap just for all their accolades and achievements. So I want to start first with Delegate Pena Melnick, and one of the main things that we wanted to talk about this year, and Delegate Pena Melnick was actually the lead sponsor on the House side of the Shirley Nathan Pulliam Health Equity Act of 2021, which was just really kind of groundbreaking legislation. And so Delegate, I don't know, I was wondering if we could start with you just kind of speaking about that bill that passed last year, the history of it, and just really how important that piece of legislation is and will be here here for the state of Maryland in terms of health equity.
Thank you so much, Delegate Williams, for having me. You know, we have mutual respect. I respect you, your work, your commitment, your passion, and I want to thank you in the city of Greenville for having me. And I am so honored to be with this panel. I know them and they are the best out there. So thank you for the honor. So I want to give a little history about the racial and ethnic minorities disparities in Maryland, and then how we got to that bill. So racial and ethnic minorities are more likely to experience poor health outcomes as a consequence of those social determinants of health, right? It is the way we live. For example, during COVID, I was helping families, they lived 10 people in an apartment. So if one was positive, they all were positive. It is the way that we live, it is the environment we live in, right? The air we breathe, you know, the water we drink. It is the lack of transportation, and it's also the jobs that we hold. And a lot of people of color are working with the public, okay? They were not and could not stay home like most of us. They could stay home and we could social distance and we could be on 10 Zoom calls. They could not do that. They were working in the restaurants, they were working in the hotels, they were out there with the public. It is the lack of education. It is also not being able to make enough money, not making a living wage, you know, just minimum wage. All those factors affect our health, including access to healthcare. You know, and it affects the level of education we obtain, the job we get, economics, you know, economic stability, housing, public safety, the neighborhood, right? So a broad body of research has actually quantified the existence of health disparities between Black, Hispanic, and Native Americans, and due to all these factors. And they are at a greater risk of heart disease, stroke, infant mortality, maternal mortality, lower birth weight, obesity, hypertension, type 2 diabetes, cancer, respiratory diseases, and autoimmune diseases. So the data in Maryland consistently shows this ongoing, and in some cases, growing health disparities in Maryland, and including the impact of COVID. So Maryland has 23 counties in Baltimore City, for a total of 24 jurisdictions, 6 million people in Maryland. The county, you know, at our worst, in Maryland with the highest number of COVID-19 cases, Delegate Williams, was gorgeous Prince George's County. The zip code with the largest number of COVID-19 cases at our worst was 20783. Now, who lives there? The immigrant community, the brown community. So that is who was greatly affected, who had the greatest number of cases. And then we didn't have access to the vaccine either. And when we decided to put these places where people could go and get a vaccine, they were actually placed where people could not get to if they didn't have a car. So the data shows in Maryland that while Blacks individual comprise more than 29% of the Maryland population, they represent 36% of the COVID-19 death as of January 18, 2021. 36%. Maryland's maternal mortality rate for Black women is 3.7 times that of a white woman. And the racial disparity has widened over the years. Maryland's infant mortality rate for all races has remained level, but remains the highest among the Black non-Hispanic population, nearly 2.5 times higher than most people. And the incidence of HIV for all races, ethnicities has generally declined in Maryland. Although the incidence among the Black and non-Hispanic population remains 2.4 times that of the total population. In 2017, ER visits for the Black non-Hispanic community compared with all races, ethnicities were 50% higher for substance use disorder, nearly 200% higher for asthma-related ER visits, 86% higher for diabetes-related ER visits, and 89% higher for hypertension-related ER visits. So what do we do now? So you helped Delegate Williams because you voted for that bill, Delegate Williams. And the pandemic encouraged us to make transformative, innovative policies. And this is why we came up with the Shirley Nathan Pulliam Health Equity Act of 2021, which was House Bill 78. And those of you that do not know, former Senator Nathan Pulliam, she was amazing, and an amazing senator and delegate. And Shirley was talking about health disparities when it wasn't the cool thing to do, when it was not popular. And that is why I thought that we should honor her, because that is her legacy. And she did the work. She did the work, and I follow her lead. So last session, we took some important first steps in passing policy that will help improve public health outcomes in all communities, because that's what we want to do. We want to close that gap. And equity is about trust and including all groups when making policy and mandates. So this commission, the commission is tasked with deploying a health equity framework that will examine racial, ethnic, cultural, and socioeconomic disparities through a health equity lens, and that is very important. So you may ask, well, how are we doing that? So the commission is a permanent commission in state government. It does not have a sunset. It is actually comprised of all the secretaries of the state of Maryland. There are at least 26, and they must meet at least 4 times a year, and they are tasked with developing a health equity framework for their departments. They're tasked with meeting 4 times a year and discussing the policies that they're putting forward and thinking, not an afterthought, how does that affect the Black and brown community, the marginalized people? We want this policy, but what impact does it have on them? And it sets goals for health equity, and it states that they must prepare a plan for the state, and they must answer the question of how are we going to achieve health equity in the state of Maryland? And the commission must examine and make recommendations on how they're going to incorporate health considerations in decision-making and implicit bias. We must talk about it. We must address it. Another bill that I want to discuss that I think is really important is a bill that I put in that Delegate Williams, you also voted for, that actually requires implicit bias training for all healthcare providers in the state of Maryland. Because we have them and we must address them, and because they affect health outcomes, the way we think, certain, preconceived notions we have and biases and prejudices about people is really important. And that was an important bill that actually complemented House Bill 78. But what House Bill 78, the Shirley Linton Pulliam Health Equity Act did, is that for the first time in the state of Maryland, we declare racism as a public health crisis. And that was important because we must acknowledge that our history has a lot to do with our policies and that we have been discriminated against. And that there are a lot of disparities and the state has to start talking about it. So I'll leave it there because I know you have other people that are going to speak. You could see I'm passionate about this. And I'm excited about the work that we have, to do. And I'm very confident that we will get it done because we're committed. Thank you so much.
Thank you so much, Delegate.
My pleasure.
So next, I'm going to turn to Dr. Hammond. You're out there every day, kind of on the front lines. And, just from your experience out there, I wanted to ask kind of what are some of the barriers that you see in terms of person of color? I mean, your focus is really in regards to behavioral health. And what are some of the barriers that you see for, Black and Brown persons in terms of engaging in behavioral health out there in the community?
Sure. Thank you, Delegate Williams, and thank you so much for the invitation. I think this is such an important topic, and I'm really excited to be here. So, but yes, related to your question about barriers to care for persons of color, I think it relates a lot to what Delegate Pena-Melnick has just talked about, and we talk about social determinants of care. That is just a word for racism, essentially. Institutional, systemic issues that can cause health disparities in people of color. And we have seen, like she mentioned, that these were just kind of worsened and highlighted during COVID. And so with that, having all these types of concerns and stressors, your behavioral health, your mental health can be put on the back burner and not prioritized, unfortunately. And you may have to make decisions about, are you going to pay for this high blood pressure medicine, or are you going to try to get some buprenorphine from a clinic, or are you going to pay for a taxi to get to the treatment center, or, so there's definitely financial barriers. I think that having to prioritize other health concerns is a big issue, as well as stigma, unfortunately. Mental health in general is highly stigmatized among people of color, and especially substance use, which is looked at as kind of a moral flaw more so than a disorder, as it really is, and a disorder that requires treatment. And so it's hard to get support from your family. Of course, community is a big thing, and among persons of color, and if you don't have the support, or people don't really feel like you need to get treatment, that can be a huge barrier, of course. And then, once you actually get there, how are you going to be treated? She mentioned implicit bias, of course, which is huge, as well as just frank racism that our patients have to deal with. And so we need to be able to get them into treatment, but also keep them, by remaining culturally competent. So having culturally competent staff, and also people who look like the patient. So a lot of times, you might not feel like you connect with certain people. And I think so. A lack of diversity, certainly in the healthcare workforce, is a big barrier as well. And so, there's a lot. I could go on and on. Mistrust of the medical system is certainly understandable, of course, because of racism and the things that have happened over the years. Something we need to continue to work on to try to prevent these barriers.
Thank you. And Dr. Anthony, one of the things that has kind of grown over the past year, especially with the COVID lockdowns, is telehealth. And so I was wondering if you are able to kind of speak about how telehealth has kind of influenced the ability of patients to access healthcare, especially those in the Black and Brown community, or has there been an increase of access amongst those in the Black and Brown community because of the increase and rise of telehealth?
Yeah, it's a great question. Thanks, Delegate Williams, and thanks again for the invitation. It's great to be amongst this group. COVID has really highlighted how telehealth has been that much more needed. What was very stark at the beginning of COVID was that the social distancing and the inability for providers to be in close proximity to their patients meant that you needed more digital means of connecting with patients and people in the community. And so telehealth became that much more important. Prior to that, there was a lot of literature, though, saying that there was something that was called the digital divide. And really what that meant is that there were persons that weren't able to have straightforward things that we think about, like internet access or bandwidth, things that would be very necessary to connect with the telehealth providers that we now see much more of over the past 2.5 years. So I've seen that prior to COVID was something that affected communities of color even more. And there's literature showing that the digital divide affected things in different ways. Some folks didn't have access to certain, phones that would be needed. Smartphone access was something that you had to think about. And also things like bandwidth, making sure that there were enough minutes on a plan and able to do a video call like this for Zoom, and thinking how much bandwidth that would take. And that has very much been shown to be affecting communities of color across the board. So I would say that patients do think about that a lot. And sometimes they try to find places that will account for the digital divide that they might have. And I've started using the term digital fitness, meaning how used to using a cell phone or an iPad or something along those lines. How used to those devices is a person, and then how is the institution used to adapting towards that? So we've been talking a little bit about the cultural competency. It gets towards a point where you think about the structural competency as well. Can the institution account for the economics of having to buy a cell phone or a smartphone or buy the data plan? Can they account for the need to have the right plan in place and the other infrastructure needs that might be necessary to continue the care that is now much more accessible to telehealth? So I think it's becoming much more important. And at the federal level, there definitely is a lot of emphasis on infrastructure. There's a presidential bill that came forward that will definitely be fit into the state of Maryland, and definitely the city of Baltimore has been working on that. I've been seeing work there from their Office of Digital Equity that they've started recently. And that's a fruit of that focus on infrastructure. Also, the FCC has allowed us to start a project that's going to increase some of our infrastructure in our existing clinics, where we'll try to look at populations that are underserved, that are struggling with accessing technology and telehealth portals, and try to increase our ability to do that there. So it's very important, but at the same time, it's very promising that we can bridge that divide.
Thank you so much. So I want to go back. We had a couple questions that we had received beforehand. And so one of the questions I wanted to go towards, we're talking about mental health, but also wanted to kind of also talk about kind of violence in general, and in particular violence against women. And so one of the questions, and this is directed to you, Delegate Peña-Melnyk, is kind of what efforts are we doing to kind of address those types of issues, especially from a health standpoint, and dealing with violence, I know, and particularly violence against women.
So thank you for the question, Delegate Williams. After the recent anti-abortion legislation passed in Texas, protecting Maryland women's right to choose is extremely important this session. And you actually are sponsoring the Pregnant Persons Freedom Act of 2022. So thank you for doing that work, which protects women from facing prosecution and civil rights civil lawsuits following an abortion. So thank you for your leadership in that, because that's really important, right? I mean, you're going through, excuse me, for lack of a better word, you're going through hell, personally, and then you're going to go ahead and be, prosecuted. That's just unconscionable. So thank you for caring and putting that forward. So, we want to keep abortion safe and legal to protect women in our state. From the potential violence from the potential violence to women and that they experience, right, every day. So Delegate Ariana Kelly, who you also know, one of our colleagues, is introducing a bill that would allow for an amendment so that we can enshrine abortion rights in our state constitution. So the measure will require a 3/5 majority from both chambers, and then it will be approved by votes in the next general election, which will be next November 8th. So it's important that we protect women in Maryland, and we actually added in our constitution. Other legislation protecting Maryland women is House Bill 153, which is Delegate Crutchfield. And it's basically seeks to repeal the current statute that makes marriage a defense to some sex crimes. And then another one is House Bill 296. They basically allow victims of abuse who are eligible to request interim or temporary protected orders to do so virtually, like Dr. Antron was saying, we're in this new world, in a hospital or urgent care setting. Because if you put a lot of roadblocks, they're not going to follow up, because they have so much that, it's not that they don't care, they just have so much to do. And another one is actually House Bill 148, Delegate Bartlett, and it seeks to expand the current stalking statute to include electronic communication and tracking devices. And that's really important, because that's being used a lot, those tracking devices. So we're doing a lot. We're doing a lot, and we have a lot of women in the legislature, and we have you in a very important committee where these laws are made. So thank you for the question.
Thank you. And just as a follow-up, I see in the chat, we have a question. What are the chances of that law to protect the right of abortion in our state passing? I don't know if you want to take that, Delegate Peña-Melnyk.
Yeah,
I feel optimistic, but
I think I will say, like you, I feel optimistic. It actually comes to my committee. So it comes to the Health and Government Operations Committee, and we have some strong women in that committee.
Yeah, you do. So yeah, I feel positive about it. The speaker has signaled that she's definitely 110% supportive of ensuring that we're doing all that we can on a state level. So along those same lines, we talked about women. I also want to kind of segue to children. And Delegate, I'm about to call you Delegate Hammond, Dr. Hammond. Maybe I'm speaking something else into existence, but anyway, Dr. Hammond, you, in addition with your work, you've also had some experience in dealing with child protective services here in our state, and just wanted to just kind of also get a sense from you, kind of how, how that's working throughout our state, especially from an equity standpoint in terms of their practices and ensuring that our children are being protected all throughout our state in a uniform manner. And, and how does that work also influence your practice?
Sure, thank you. And I will keep the delegate title for you all to do that really tough work, and I'll stay in my lane here. But certainly I have had a lot of experience working with child protective services, having worked with pregnant and parenting women with substance use disorder. And so we have found that it's really hard to kind of predict what CPS is going to do, unfortunately. And so we could only, really help to prepare our patients for either outcomes. And, we have noticed that certain counties are, maybe a little bit less restrictive, like certain, like Baltimore County compared to Baltimore City. In general, we tend to find that in the county they may support, staying with the mother, staying with the baby, more so than in the city. And it just depends on not only county to county, but also worker to worker. They have in the city, they have Baltimore City, they have a special unit for substance exposed newborns. And so, they get a certain amount of training, but unfortunately that unit is understaffed. And so there may be someone who's assigned to one of our patients who doesn't have any experience in that area or knowledge in that, in training specifically. And so, in that case, we really don't know what could happen as well. And so we really just try to work closely with CPS to make our best recommendations and do what's best for the patient. But it is hard when there's no kind of standardized process among the various departments in the various areas in Maryland. And so, and it can be tough with not only retaining our patients, because word gets out that, oh, you're a patient at CAP, you'll definitely have a case, or and so that can be kind of an issue for not only getting new patients at our clinic, but also actually retaining the ones that we have, especially when CPS makes a decision that we wouldn't normally, wouldn't agree with, for example, and the other patients, they talk about it, and so they know. So it's hard, but we try to really work with like the supervisors in each department and try to, we actually have been working with them to do some education and training for their workers, as well as providing information about some of the gold standards in the treatment of pregnant and parenting women with opioid use disorder in particular, so that hopefully we can really extend best practices among the different departments for our patients.
And just kind of as a follow-up to that, do you feel as though there is enough access to deal with kind of the opioid use disorder here in our state? I know Governor Hogan, especially when he first was elected, kind of really highlighted the abuse of opioids within our state of Maryland and how that had been increasing over the years in all of our communities across the state, whether it's urban, rural, or suburban. And so I guess my question is, in terms of access in trying to deal with the opioid crisis, do you feel as though as a state we're doing a good job and being equitable about that within all of our communities across the state?
Well, I think that the overdose deaths among persons of color would probably say no. Certainly, as you said, the state, use of opioids and opioid overdose deaths have certainly kind of skyrocketed in the last 5-6 years, but certainly at worse among persons of color. And we are just seeing all of that heightened by COVID, unfortunately. I think that we do have a good number of opioid treatment centers, but you have to look at what is the quality of care that they're giving, and certainly certain areas that is lacking. We tend to get people from rural areas that don't have access to care out there, especially pregnant women, and we do get some referrals in the city from other clinics that don't feel comfortable taking care of pregnant women. So I think there's a lot of improvement to be made in our current centers that we have to make sure that we are giving the best care, that we are trying to work on addressing some of these barriers to care that we've talked about, and also kind of retaining the patients that we do have. We have various medications for opioid use disorder, such as buprenorphine, but while we are making it easier for physicians to be able to prescribe it, they have to also feel comfortable and feel like they have enough training for that. So, we certainly could increase the number of physicians who are prescribing that, hopefully persons of color or those who are culturally competent, so that we can hope, get more persons of color interested in seeing those physicians. And then methadone itself, of course, has a lot of regulations that create even more barriers to care, including having to come every day when you first are started on it, and just how that could affect your just regular life with work and all of that. So I think we have a lot of work to do, certainly, to help improve access to care in the state.
And then I see there's another question in the chat. I'm gonna start with Dr. Antonine for this one. What are your thoughts on the long-term mental health repercussions for kids from the pandemic? We have this lack of in-person school, lack of normal socialization due to isolation, loss of parents, and I'll just add family members as well due to COVID, financial hardships, and things like that. And I don't know if you're seeing any of this in your practice. I know we're kind of seeing it from a policy standpoint, just, with the increased number of just, well, I'll speak for myself since I serve on judiciary. We're seeing from a criminal standpoint, just this increase of crime amongst juveniles, especially in terms of like carjackings and crimes of theft and things like that. And so I just want to kind of get your take on kind of what the, from a mental health standpoint, how is this really affecting, especially our children during this time?
Yeah, I mean, this is a really psychological crisis in addition to a COVID crisis and an opioid crisis. And psychologically, you always think about stages of life for a person and having to, the goal is to have a person navigate through the stages of life successfully, so there's decreased amount of conflicts when they get to adulthood. I think what you're seeing with all that's been pointed out in this question is that each of those stages can be altered in different ways. So for the children that are coming through and for the family units or whatever type of unit that are coming through, that is under attack. And so that could mean the main breadwinner, whether, woman, man, whoever it may be, that person may not be there as much. Or, the example of healthy social relationships, that's not there as much. Or isolation, or as was pointed out in the question, the lack of a socialization at an early age, and what does that build for relationships downstream? All of that is under attack. So, it goes back to what can you do from a treatment standpoint, which is essentially tertiary prevention, where something has already happened and you're trying to reel it back a little bit, versus trying to amplify what would be more the primary and secondary prevention when you're targeting individuals who might be at risk for these type of downstream issues. So from a policy standpoint, I think there's an opportunity to say, maybe we think about things that could preserve that family unit better, or look at different socialization things in the community. So, me growing up having an after school playground to, play on that safe, or different activities like band or things in the area where I could, coordinate with different people and learn different skills that we end up teaching in our programs for substance use disorder treatment, because we have to teach resocialization, but now you have to think about it from earlier on in life. And so, the policy, the magic policy, I don't think I could put it out here right now, but I would say that it's going to depend on something that will preserve and grow the family unit, or whatever unit will get that person to the next stage of life successfully. So I think it's going to be a great amount of work for people who are picking this up in the next 5 to 10 years, because it'll be a question to answer for a while.
And also, I'm gonna stay on you for a second. Dr. Hammond had mentioned barriers to access to care. And I guess one of the questions I had is that once some of those, you finally do meet a new patient for the first time, what are some of the barriers that they talk about in terms of getting, access to care for that first time, and the things that you're hearing from your patients out in the field?
Yeah, I think it's, I'm hearing a lot of things that have been reflected in the National Survey for Drug Use and Health, which is a survey that's been done for a while now by the Substance Abuse and Mental Health Services Administration, one of the federal entities. And what I'm hearing really reflects what is in those studies, which is, hey, I had to drive a really long way to get here, but I'm glad I got an appointment, or I had to wait 2 months to get an appointment. Or there's no one that really looks like me or understands the terminology that I'm bringing to the table, code switching, if you will. Those things come up a lot. But then it comes down to some of the basics, like, I don't know if my insurance works here, or I don't know how to get to a primary care doctor. I don't remember when I got to a primary care doctor in the past, or who to go to coordinate all of that. Unfortunately, half of my folks don't have things like electronic medical records or a way to reach those regularly so they could send a quick text to their doctor. So they also want to know how to reach me after 3 o'clock when I might not be physically in the office. So access in different ways comes up. And I'm starting to figure out, how can we get things to the person rather than the person having to come to us. And that's been a big thing that we've been doing in Baltimore at Helping Our Mission. We brought a clinic that was on one of our medical campuses and moved it into where homeless persons with substance use disorders are actually living. So they have to go 20 feet instead of 20 minutes on a bus or more, given that the bus routes have changed. So that's the nature of what's been going on. And I think, Dr. Hammond's been working also on getting a good snapshot with that, so we can really understand who the person is coming in the door and quickly make an intervention and hopefully a referral to the more specialized treatment. So the person coming in the door is not spending their time, rather than, what we should be doing, which is putting our time towards getting that crystallized picture early and then getting them to the services they need.
So it sounds like also, I guess, kind of also health literacy is something, I guess, that needs to be addressed. And Delegate Pena-Melnick, I know during the pandemic, you did a lot of work here in Prince George's County and really trying to get information out into the community. Not just about where people could go for testing or for vaccines, but just really what was really kind of going on health-wise. And I don't know if you want to speak about kind of just dealing with health literacy within the Black and Brown community and the challenges that we were seeing, especially at the height of the pandemic.
Thank you. And, there was a lot of misinformation out there, especially on social media. So we need to inform our community. And I don't want to say educate, I want to say inform our community on the importance of reading and using a trusted source to be stricter about who are you believing, who can you trust? Is it your church? Is it the pastor at the church? Is it your representative? Is it your doctor, right? And that is really important, because when we were saying at the beginning, you need to get vaccinated, and people there was all this misinformation out there, we had to break it down and explain it, how, the studies that were used, to test the vaccine, how for the first time, these studies were diverse and they have Black people and Latinos in them, right? And you had to also show to the people how, if you do not get vaccinated, the odds of you ending up intubated in the hospital were very high, and you showed the numbers. You have to show how you have to believe in the science. There was a time where we, Delegate Williams, we believed in the science. Now we don't even do that. And that had a lot to do with what was going on in this country and who was leading it. No offense to anyone. And the messenger is so important. So this session, I'm actually sponsoring the Health Literacy Infrastructure Act, believe it or not. And you didn't know that, but I am doing that. And it's health literacy is the personal capacity to find, understand, and use health information and services. Healthcare organizations also have a responsibility to help people find, understand, like Dr. Antoine said and Dr. Hammond, where do I find a doctor and what kind of insurance I have, and read that small print. What is covered? Do I have a copay? What am I going to be left here with? It is essential that health information and services are accessible and understandable through accurate and consistent evidence-based plain language information that is culturally and linguistically appropriate. And that is important. So this bill proposes that the University of Maryland Horowitz Center for Health Literacy Center serves as the state's designated entity to advance the state's health literacy infrastructure. So they're going to act like a hub, right? The center will serve as a consumer health information hub to promote and ensures the public interest is accurate, that is consistent, plain language, you know, and that we find out what is the preferred language that we need to communicate so that a person can inform their decision because it affects their health.
That's awesome. See, this is why, so Delegate Peña-Mills, this is why she's such a leader in the General
Thank
Assembly
you.
and just in our state, in our community in general.
Couldn't do it without your supporting the vote, you know?
Oh, no, you'll definitely have my support on that. But yeah, that's amazing. That's definitely what we need right now. Definitely. So there's a follow-up question in the chat. So how much in terms of the health literacy, how much of that was due to the fact that, you know, earlier we talked about a lot of times, especially for Black and Brown individuals, they may not have a dedicated primary care doctor, or like Dr. Antoine said, you know, they don't remember the last time they saw a primary care doctor or had a physical or anything along those lines. And so how much of that is possibly attributed to that is the follow-up question. And anyone can take it.
I mean, I'll jump in on that. I think that there are a lot of conditions that could be caught, but you know, I recognize that primary care doctors don't have as much time available as they used to. And there are a lot of factors there that could be a whole 2-hour conversation just with that alone. But I think the more you talk with someone, the more you're able to paint the picture of what's going on with what's going on. So it is a great place to start. Especially with the things that might have been exacerbated, made worse by the COVID pandemic, or, you know, a person's just not having the same reaction as they used to. Having that maintained relationship is a good base layer to have. So would it get rid of everything? No. But it would be helpful, absolutely, because you could at least maintain, you know, a connection with someone and say, well, you know, I am having this pain that comes on when I feel really sad, like a PHQ-9, that's a standard screener. And you know, hopefully the primary care doctors would be connecting with specialists like Dr. Hammond, myself, and others who could get to the nitty gritty of what else is going on. But it plays a role. It does play a role.
And also too, do you feel that patients have a tendency to gravitate towards a certain type of practitioner when they're choosing who to engage for their treatment?
Yeah, I think that's a good question. That's a question that's been studied for decades now. You know, there's a person, Jerome Frank, who did a few studies back in the 70s to figure out who would have the most important influence over a person when they come in for treatment. And really what they found is whoever is important to that person. So I do think that people do try to seek out someone who's important to them in some way, whether they look the same, sound the same, sometimes have a similar background. They, have that code switch so they can, speak the same type of language, if you will. And just, what I've come to tell my folks that come in the door or come in my screen now, I tell them that they should be looking for someone like Bob Ross. And Dr. Hammond's heard this before, and other people have heard this before, but I say it because they should be looking for someone who's taking the time to paint the canvas of what's going on in their life accurately. And if they don't find that person who is painting or taking the time to paint, that might not be the right person. So sometimes a person might seek out a provider who might have the degrees or might have the established name in the paper or somewhere. But I think what they should be looking out for is someone who can take that time. And sometimes it's the primary care provider. Sometimes it's someone who's culturally competent, but it should definitely be someone who has the inclination and desire to make that whole painting over time, so you can get the person to the right set of treatments that are needed.
I want to kind of segue a little bit back to Dr. Hammond. You talked about, your work in working with pregnant women, especially with pregnant women who may be, engaging in drug treatment. And how does drug testing in facilities where pregnant women receive treatment affect your patient's willingness to engage in treatment? Is that something that we're seeing as well?
Um, Definitely. So, in the main place where I see the biggest concern is on labor and delivery. So when they are actually having their children, right now, it depends on what hospital you deliver in as far as if they do universal screening on everyone who walks in the door versus, deciding to test a pregnant woman just based on, whatever information they have about her already. Or a lot of times that could be driven by their own implicit biases. And so I think there are sometimes concerns that, every patient that comes to our clinic is going to be tested and is going to have a CPS case, like I mentioned before. Whereas, there are a lot of women in like suburban areas, for example, like soccer moms who have Percocet use disorder and maybe on buprenorphine during pregnancy. And I've heard of some physicians that are inappropriately taking them off before they deliver so that, they won't be positive for it or there won't be any record of their being on bupe. And so, which is very dangerous for the baby because the baby could go through withdrawals. But because of their socioeconomic status, they may not be tested when they go to the hospital. They're likely not to be tested. And so I think that is a big concern because a lot of our patients come by word of mouth. And so, if they are thinking that just being at our program is going to be detrimental for them, they're going to be automatically tested or, automatically have a CPS case that can kind of deter people from coming to the program or staying through pregnancy, delivery, postpartum, et cetera. So there could be dropouts related to that, unfortunately. So it definitely has been an issue.
Oh, okay, let me unmute. You would have thought by now, would have figured that out after 2 years. So one question that we also received beforehand is whether or not you can tell us, and this is for all three of our panelists, some positive results that we've seen recently in Maryland due to a lot of the kind of work that we've been doing over the past year in trying to make healthcare more equitable within our community. We've kind of talked about some of the the sad parts, but are there any positive things that we're seeing right now? And I guess I'll start with the delegate.
Thank you, Delegate Williams. I would say that, our communities of color are getting vaccinated. There's not that hesitation that everyone was saying. We don't have the hesitation, some may, but we just need to understand why we're doing it and the importance of it. And the good thing that I see is that, we are investing in getting the message out. The state is investing in getting the message out. We are investing in our public health infrastructure that has been underfunded for so long, for decades. And we have a lot of great bills this session that will do just that. When you think about mental health and you think about I hope this is not a trigger for anyone, but the number of people that are committing suicide is so high. And we have bills to deal with that in this particular session. We have bills to deal with the fact that people with mental health do not belong in the jails, in the prisons. They need services, and we have bills that would get the police officer out of the equation and bring in mental health professionals, bring a certain team to the hospitals. And we have bills that deal with providing more crisis services in bed this particular session. So that is a positive thing that came out of it, that these inequities and disparities were highlighted to the level that we can no longer ignore it, that we know that we need to invest in our public health system, but most importantly in people. And that is really important, right? We're doing things like not requiring, you don't have to pay for your vaccine to get a vaccine. We got rid of the co-pays as well, right? To make it accessible. So I say we're doing, I feel optimistic.
Good. Dr. Hammond?
I definitely agree that COVID really highlighted some of the disparities that we are dealing with. And I think that one good thing has been that everyone was stressed during COVID. And I think people started to realize that, you know, our mental health is important. We need to prioritize our wellness. And I think so that, you know, talking about mental illness has started to decrease the stigma associated with it. It started to normalize it. And I think relatedly, we were able to kind of sit and be still, and now people are realizing, okay, yes, there's systemic racism, and this also affects our mental health and you know, Black and brown people. And so I think that has certainly been an improvement. I think I got more calls to be involved in panels like this in terms of talking about mental health in general, but especially for the Black community since COVID hit. And I got probably more calls from people that are interested in getting treated. They're looking for like Black doctors. And so I think that the decrease in stigma has been the biggest thing that I've been happy to see.
It's hard to follow those two. I would say that I would say that equity has a different spin. If you look at it, it also means value. And what COVID has done is made us re-examine the value of things. We've had to sit still and look at things that have happened at our nation's capital with police brutality, things that if we were walking around doing our normal things, may not have had as deep of a focus on. And I think what that's meant is we're now saying, where should we put our time with that value? And how should we increase the value of the people that matter? So for me, it's been putting time towards places where we normally wouldn't have treatment. And I think it's allowed us to really say, we need to increase the value of the treatment that we're putting towards certain people, whether it's through increased funding, different laws. But I really think in different ways, we've said, all right, let's bring down the barriers so we can have more valuable interaction with the people that do need these services. So it's just another way of looking at equity.
So I'm going to open it up for anyone on the line, if there are any questions that folks may have, if you want to place them in the chat, or if you want to use kind of your raise your hand function there, if folks here have any questions that they want to ask of the panel. No. Okay, well, I'm gonna go in. And I guess this is to the doctors, from a policy standpoint, are there any, I know we talked about a couple of different measures. Is there anything else that you can think of that you would like to see from a policy standpoint that you think would be helpful or beneficial into kind of breaking down some of these barriers, breaking down the stigma, and you know, making it easier for people to get access to quality health care?
I'll jump in first. You know, I think some of it's going to be financial, and making sure that it's easier to get certain medications, especially medications for opioid use disorder treatment. And I know there's certain legislature being considered at this time to think about whether there needs to be pre-authorization or prior authorization for certain medications. And I think things like that will be crucial to consider as we get towards other types of treatment. And I do think that in order to decrease stigma more, there's going to be opportunities to not just have the cultural competency, which I was very happy to work with Delegate Melnick on when that went through, but thinking also about how providers who might be at risk for stigmatizing treatment, how they are going to be forced to have certain types of communication to decrease that type of stigma. Already for persons who need their controlled substances license, we have to do some type of training. And I'm thinking there could be policies downstream to ensure that a person who might not have that much knowledge about substance use disorders, for instance, must at least have a quick phone call with one of the established state lines that's there for advice, so that non-stigmatized treatment and evidence-based treatment is given rather than perhaps substandard treatment. So something along those lines, I think, would be a start. And I'm sure I'll think about a couple as Dr. Hammond is putting her thoughts out there as well.
Yeah, you know, working with pregnant and parenting moms, I think that really working to do a better job at who is being tested in L&Ds, and also how those cases are managed in terms of giving more training to our Child Protective Services workers. They definitely could use a bigger budget to make sure they're not so short-staffed. I think also, with the kind of loosening of restrictions during COVID on some of our more highly regulated medicines like methadone, we have seen that it's been a little bit more patient-centered care with being able to give out more take-home doses for our patients with methadone, not having them have to come in the clinic every day. And so that, in addition to the kind of a liberation on restrictions of telehealth, has also been very helpful. And so I'm hoping to see more of those kind of changes that are patient-centered and that we're seeing have been helpful for our patients.
And then Brittany Durham, you have a question?
Yes, hello. I'm a student at Eleanor Roosevelt here in Greenbelt. My classmates and friends, Mary, Shayla, and Jenny are here also. And we've been listening and we've been really engaged and interested in this conversation. We're actually doing a project about health and nutrition in the county and in Maryland. And we're doing a documentary sort of thing. So we've been taking notes and really engaged in the conversation. So we wanted to ask, we're looking at communities that have trouble accessing poor healthcare, nutrition, proper access to healthy foods. So we are wondering, can you give us your thoughts on how these kind of barriers to proper nutrition impact people's health? Thank you.
Unless anyone, okay, I'll jump in on this. This actually was a big project of mine early on in my career, so I kind of have a thing for this, and also a couple of my colleagues and one good friend is a graduate of Eleanor Roosevelt, so good to hear that come through. Taste is an interesting thing. There's actually a little bit of evidence that I found that the things like sugar and salt build over time, and just as you eat more and more of it, you get less sensitive to it. So it means that your choices are going to be guided differently as you get older. And if you start out with only being accessible to high sugar or high fat or high salt foods, you'll be making those choices for a while. And if you try to suddenly reduce it, you'll say, this tastes terrible. I won't eat this regular sodium food or this regular sugar food. And you might end up just being steered towards these tougher choices, similar to a person who's taking higher amount of opioids over time. It's harder for them to cut back. So there's similarities with that food reinforcement, just like drug reinforcement. The other piece with that is, as a person grows up, not everyone's necessarily aware of what are the healthy levels of those nutrients. So if I were to tell everyone on this call that they're only supposed to be, eating, or African Americans or persons of color should only be eating 1,500 milligrams of sodium a day, that part of people would be like, I don't really know how much I eat a day. And that's a study we did a while back, just to sit down with people and think, how much do they really think they're eating and how much should they be eating? And that's a big place to start, just right there. So I think it could have long-term impacts, because if a person is eating much more of a nutrient than they're supposed to, there could be more things like hypertension and diabetes and heart failure and things that become of that. And so the education becomes very important, and also how to affordably access the healthier ways, because without that affordable access, just like we're talking about with the structural competency, it's going to be difficult to drive 20 minutes to the Whole Foods, pay for the whole check, as some people call it, and then come back home. So there's a lot tied into that, some physiology, some social, but I think that's an important project to really carry forward.
And if I may, Delegate Williams, what I would do, I would try to get Dr. Antoine's email and interview him for that project. I was able to get those bills, the Shirley and Pulliam bill through, and the health equity, right, one, and the implicit bias training, and another one that I put that requires data collection in Maryland, because Dr. Antoine and Dr. Golston helped me, and they testify in those hearings. And it was important for me to talk to doctors of color that get it. I'm so grateful to you, because I really think we made history, and I couldn't do it without your help.
No, thank you. Your driving force behind that was very important. So I was happy just to tag along.
Awesome, awesome, awesome. So Katie has a question. So Katie, if you want to go ahead and ask your question.
Yeah, to tag on to that whole nutrition question, first of all, I'm excited to see the Roosevelt students, Eleanor Roosevelt students engaged in this. Good for you. So what about the availability, knowing what's good and what's not good, and the availability of good things? I remember being really frustrated when we never had soda at our house and chips and that kind of stuff. I knew that the kids were eating it at their friend's house. That's fine, you know, but as a rule, we didn't have it here. So I was really irritated to find out that both kids now have a taste for soda. And I said to him, how did you get a taste for soda? Because to go to Dr. Antoine's point, I had read that study that talked about if a little child gets started on sugar and salt, that's all they know, right? And it's hard to go back. And so I thought, well, they didn't get that at home. How did they get this taste? And they said, oh, we started buying sodas at their middle school. They had soda machines that the kids could access. And the schools had the soda machines because they were using it to make money. They didn't have enough money. I'm like, I mean, it's very frustrating.
It is. And I think, you know, there are even policy ramifications. There was a colleague of mine who used to do studies about mapping the different neighborhoods to see what type of stores are available. And you can understand how there could be policies and other things involved in determining what type of stores, whether it's liquor stores or grocery stores or other stores, how that population density can say, if I'm walking a mile, what choices will I have? So, you know, food deserts are big. That's where, you know, people do not have access to the right things, but it's also a part of the picture to say what is accessible in a reasonable amount of walking time, because I know where I grew up, you know, walking and taking the bus, and a lot of people do as well. So if you only have a liquor store or you know, fast food store, that's all you're going to be able to afford. And sometimes the Happy Meal is affordable. That's about it. So it's a complex situation in different levels, but I really do think in the future that's something I hope will get developed and will from a funding standpoint as well.
Absolutely, absolutely. I mean, I think we're also having that policy conversation right now as it relates to food deserts. And I know we've talked about that, especially on a county level, and we're going to have some conversations, I think, about that tomorrow, Delegate Pena-Melnick, on how we address the issue of food deserts, especially here in Prince George's County. And I know there are a couple of different policy ideas centered around trying to reduce the food deserts here in the county. And so that'll be an interesting debate on whether or not, you know, what tools we utilize to try to stem that tide or deal with that problem. So it'll be fun. Let's see. Anyone else have a question? I think there was a question that was in the, let's see. I think I saw someone send me about diversity in the healthcare field. And so the question just has to do, it seems like there is a lot more diversity in healthcare. Interested to get people's perspective on that, and kind of where do you see the future of healthcare, especially attracting more persons of color within the field of healthcare. I know, especially during the pandemic, one of the things we try to do, you know, I always talk about the shortage of nurses. And so we try to ease some of the restrictions in terms of getting more nurses on board with our hospitals and our clinics and centers. And so just interested to kind of hear you all's thoughts as it relates to that in terms of diversity in healthcare.
I do see it improving. I think it's similar to our patients. You have to try to decrease some of those barriers that are there to entry into medical school or various professional schools, as well as increasing retention through those schools and throughout their training process. But I think that there's still a small percentage of Black physicians, for example, definitely could use more, but there are, just like in other fields and other areas, a lot of barriers that could be related to racism or other things that are keeping us out of certain areas. So whether that's testing that's not particularly culturally competent or biased in some ways, and a lot of times getting into certain schools is related to your network, and so that could be a barrier as well, and not having mentors or people who you have access to know how to kind of get into these circles. But I do think that's improving. I think that medical schools are paying more attention to the need for diversity and equity and inclusion and just the importance of that. And so I'm hoping that it continues to improve and not just isn't just like a fad or a trendy thing. But I definitely have seen some improvement recently.
My one addition to that great answer from Dr. Hammond would be, I think, I hope we get to a point where we're saying diversity, equity, inclusion, and retention. I think retention is an issue that we just haven't had enough spotlight to deal with yet or to think about yet. And part of that's going to be for retention of patients in healthcare settings and for health practitioners in healthcare settings. And it's going to mean really looking at those settings to see whether there's a sense of belonging for both of those categories in those places, because oftentimes people don't come back because they just don't feel like they belong. And so I think that's going to be something that could be measurable downstream, but is something that's the next step after equity and inclusion. We want to keep people in the salt shaker, the salt and the pepper, and shake it up and make sure it doesn't leave the salt shaker as well. So there's a lot of work to be done, but I'm hopeful, like Dr. Hammond is.
And if I may speak from the legislative perspective, we have a lot of laws and have had in the last few years that actually add the word equity, inclusion, diversity to a lot of the laws that we pass. And one particular one that we have this session is one where Blue Cross, which is the carrier with the highest number of patients, right? People that they cover, insurers in the state of Maryland, right? They're the biggest one of all. And they have a board that is very important, right? These boards are so important. That's another place where we people of color need to serve, is on these important boards, right? Where the policies are created. And their board, they actually have a bill where they are adding an individual with diversity and inclusion background. And you would have never, have seen this before, right? And now we have it in front of us. And it was interesting to see the discussion in committee where, a couple of members were saying, well, why do we need to legislate that? Why is that needed? And it's interesting because we have to explain why, right? We get it. And the fact that the question was being asked makes you wonder, right? That's exactly why it's needed. So it's important. It's really important to have a diverse workforce. I always say you can be what you can see, which is so important. And I think that if you see the field being represented by Black and Brown and Asian and just a diverse group of people, then that when a patient comes from that background, they feel the way we started this conversation, they feel more comfortable. They're going to follow up with their care, right? They're going to adhere to their medication routine, and they'll be more open because they can relate to you, and that's important.
Are there any additional questions from the audience? Oh. But I think,
Actually, yes, I do.
yeah, go ahead.
Sorry, I couldn't find the raise your hand feature in
It's okay.
time. But hi, I'm Mary. I'm also a student at Roosevelt, and we had the same idea actually as Delegate Pena Melnick, I think. We were wondering if anyone here had experience in nutrition and would be willing to be interviewed for our documentary. Anyone at all? Yes, thank you. Please, could you give us your email in the chat so we could contact you about this?
Not a problem at all.
Thank you so much. And anyone else who would be willing to speak.
Awesome. This is so awesome that you guys are working on this. So I'm looking forward to seeing the final product from you guys. This is so great. So yes, and so this has been a really awesome conversation. I realized we were talking about kind of implicit bias earlier, and I just was thinking in my own head, like, I just thought about, like, for me personally, like the majority of my doctors are all women. And I don't know, I mean, if that was my own personal implicit bias in that thought process, I feel like it just sort of happened, but probably not. And so, I think this has been a really great conversation for us to have as we kind of talk about this and talk about how all of, race and equity and all of that really also influences our decisions in terms of our medical care and treatment and how people interact with our medical system. So Leanne Irving is on the call. She is one of the co-chairs of our Black History Month committee here in the city of Greenbelt. And so I'm gonna give her an opportunity to say a few words. So Leanne.
Yes, well, thank you to all of our speakers. I know you are very busy, and I appreciate this opportunity to build a little community, because we know that building community makes us all healthier and happier. So even through the internet, we can kind of build some community. I got to attend, I'm in the healthcare field, I'm a shiatsu massage therapist, and I got to attend several of the annual meetings on health disparity that Senator Nathan Pullian had begun, so many years ago, and they were so inspiring to me. So I encourage the students, perhaps you can attend next year, depending on how old you are, but it's a statewide conference with healthcare professionals. So there's rural people, urban people, people of with different languages in different healthcare fields, all talking about their particular needs and concerns. And it was fascinating and very inspiring. So thank you so much, people, for joining us. We are honored to have you here. And I want to say that our health is so precious. I was so sad to read about the suicide of the Hyattsville mayor recently, just in our own county. It was just shocking. So let's keep building community, and I hope perhaps to meet you in person at some point. Thank you.
Thank you, Leanne. Thank you. Yes, hopefully next year we will be able to do this in person. We had to pivot to a virtual environment this year for everyone's health and safety, understandably so. But hopefully we will be able to kind of, I don't want to say go back to normal, because our normal, we know, was filled with lots of turmoil and disparities, but hopefully we can go back to better, and including an in-person aspect to our better future. So with that, I want to thank our panelists so much again, like Leanne said, for taking the time out this evening. We really appreciate it. Greenbelt here, we always are embracing our diversity, which is one of the reasons why I moved here so many years ago. And so I just really want to thank you guys so much for being here this evening. And yes, and Dr. Antoine will get in contact with the kids there. All right. Have a good night, everyone. And thank you so much.
Thank you so much
Thank
for
you.
having us. Bye.
Thank you for having
Good
us.
night.
Have
so
a
much.
blessed
Bye. Have a good night.
Bye.
Thank you.
Thank you. It was a pleasure seeing you all.
Likewise.
Bye-bye.
See you soon.
Bye.